So thank you for your question, because I tried in my presentation first to explain which is the time frame between the approval of a drug in the metastatic setting that will arrive in the early breast cancer setting. And there is a range that is between 10 years in the 90s to 4 years today. Just if you remember pembrolizumab, it was approved in the metastatic setting at least 4 years before the data have been translated in the early breast cancer setting. But the most important point I raised is how to predict a benefit of a specific drug in the early breast cancer setting in terms of overall survival. Because in my opinion, a drug is really transformative if you increase the cure rate. And the cure rate, namely, is an overall survival benefit. All the clinical trials are designed having as a primary endpoint or PCR, or invasive disease-free survival, or event-free survival. As I said in my talk, we have statistical methods on the patient level and the trial level to better understand if a drug will be positive on overall survival or not. And one of the methodologies is the coefficient of determination, R-square. If this is more than 0.7, usually there is a strong correlation between PCR and overall survival. If between 0.5 and 0.6, usually there is no correlation. And if you check at the data in the clinical trials for pembrolizumab, this was exactly the case, because an increase in PCR was also related to an improvement in overall survival. So in future trial design, you need also to apply this specific methodology. But in advanced breast cancer, of course, is another issue, because in that case, you don't need for sure overall survival. Sometimes you may have, some other times no, because personally I believe also response rate and progression-free survival is a valid endpoint in the metastatic setting. So metastatic disease is not curable. The impact on overall survival cannot be guaranteed due to the biology of the disease. So in advanced breast cancer or metastatic breast cancer, I believe still PFS is a valid surrogate endpoint. This is an excellent question. I believe in some disease like HER2 positive, we need to design a clinical trial in which potentially cure rate can be really the primary endpoint. I mean, if you have a de novo metastatic disease with an oligometastatic presentation, don't you believe that we can achieve to cure some of these patients? Now we have a very effective treatment. So it's important that societies like CISCO, ASCO, ESMO may work together to promote clinical trial in very special populations that maybe are rare if you consider them in a single center or in a single country. But there are many if you collaborate on the global level to specific unmet medical need like cure in advanced disease. So this should be the effort of all scientific societies together. We cure a lot of patients now, because with the early diagnosis the cure rate is very high for triple negative, HR positive and HER2 positive disease. So I believe what we need to improve now is optimized treatment in order to reduce toxicity. So we need innovative trial that beyond cure, they should consider also toxicity of specific agents, because in my opinion, if you have to cure a patient that is a low risk with 5 years of endocrine therapy that may impact on the quality of life of those patients, if you have a trial that is a non-inferiority trial in which you demonstrate that an alternative regimen can achieve the same results in terms of cure rate, but with less toxicity. So this is what we need maybe in the interest of our patients.